Hi everyone. My name is Alan Bunhui. I'm a year 2 semester 1 student for the Bachelor of Medical and Health Sciences program. And today I have a one case presentation regarding on the clinical practice trauma and emergency care Nbcp 2626. So this is a brief history of the patient. So patient is a 67 years old female Chinese Malaysian brought in by the EAP team to the critical zone. So the mechanism of the injury: patient was a front passenger, a large road traffic accident at 9:15 a.m. on 29th of December 2020. Patient was a seatbelted patient, so heated front dashboard with a speed of 100 km. So primary survey was done in on the scene. So start with A, airway, and C, spine control. So patient can speak in the first sentences. So consider patient has having a patent airway, so no stridor or wheeze. During inspection, no bruises, no hematoma upon the neck region, no spontaneous bleeding as well. So upon palpation, no bony deformity, no crevitus. So immediate action, I do immediate actions: manual inline stabilization and apply the cervical collar. So continue with B. B stands for breathing and ventilation. So respiration rate was 20 reps per minute. SpO2 was 99% in the room air. So inspection was done. Equal chest rise, adequately mild redness upon the left chest down to the right abdominal region. There are a seatbelt shape noted on patient. However, trachea was midline, no deviation. Palpation was done. Chest spring shows negative, mild tenderness and symmetrical. Percussion was done as well, both side resonance, auscultation. Findings: A entry was bilaterally equal. Heart dual rhythm, no murmur, no mouth sounds. After finish with the B, next we move to C. C stands for circulation. So circulation pulse rate was 69 beats per minute. Pulse volume was good. BP was recorded 111 over 83. Capillary refill test was less than 2 seconds. Warm skin. Abdominal finding: during inspection, there is bruises over the lower abdominal region. Mild redness upon the upper abdomen, which is the seatbelt shape. However, there is no hematoma, no wounds or active bleeding seen. Palpation was done, showing tenderness guarding upon the umbilical region. Fast scan done as well, showing free fluids at the Morrison pouch and splenorenal interface. So pain control was initiated at the scene by giving IV morphine 2.5 mg. This is the example of the seatbelt sign over the lower abdomen. Finish with the abdomen region, so we go to the pelvic region. Inspection: there is no deformity. Palpation: pelvic stability was done, showing negative. So long bones inspection: there is no deformities or bruises or hematoma, and even no any active bleeding was seen. Palpation showing no. Finish with the C, we go to D. D stands for disability for the primary survey. Disability plus neurological assessment. GCS was full. E stands for eye, scoring 4. V verbal, scoring 5. And M scoring 6. Pupils were equally reactive to light. Size 2 mm bilaterally. Moving off limbs. Finish with D, we go to the E. E stands for exposure. Exposure: there is noted multiple abrasion or wounds over the left hand. However, there is no deformity seen. Log roll was done, showing no spine tenderness and the anatomy was intact. So normal saline dressing on the wounds was done. E stands for event. Event lead to the injury. So patient was alert RTA around 12:30 p.m. Heated front dashboard but patient was seatbelted. Head to toe examination: there is a redness over the left chest down to the right abdominal region and having multiple abrasion wounds over the left hand. So provisional diagnosis on this patient is pneumothorax. Second is intracranial bleeding. Third is a cervical spine injury. Fourth is the intra-abdominal injury. And the fifth is the ribs fracture. Investigation was done. For blood investigation, we took FBC, BUS, and GXM. For X-ray, for the radiological investigation, we took chest X-ray, pelvic X-ray, cervical X-ray, and thoracolumbar X-ray. For the CT scan, we took CT abdomen, and of course, the fast scan as well. This is the FBC, and this is the liver function test. This is the management we done in ED. First, we continue on the cervical collar until the clearance of cervical have been done. Next, we give another pint of normal saline, 0.9%. And insert the IV transaminase acid 1 gram state and insert the CBD to monitor the urine output. Also, we obtain the written consent for the blood transfusion. After obtain the written consent from the patient, we immediately run the 1 pint safe O to the patient and send it for CT scan. And we do the reassessment to the patient until we refer to the surgical for the further management. So this is the nursing process. Pain related to the disease. Initiate the pain control management by reducing the pain score. Anxiety related to the hospitalization, we oriented and explain any kind of procedure to the patient. For the risk of fall, we prioritize the safety of patient by locking up the bed and pull the bed rail. So this is the finding of the CT abdomen. Okay, finish with the case presentation. We next go to the blunt abdominal trauma. Okay, we have set up I have set up two main objectives, which is the general and the specific objective. For the general objective, I hope this study is to learn about the management and the responsibility while treating the patient with a blunt abdominal trauma. So there is 4 remaining specific objectives, which is number 1, able to recognize the signs and symptoms of blunt abdominal trauma. Second, able to know the pathophysiology of the blunt abdominal trauma. Third, able to initiate a proper management to the patient with blunt abdominal trauma. And lastly is to know the responsibility and roles as a paramedic in managing patient. So this is the definition for blunt abdominal trauma. So blunt abdominal trauma is a leading cause of the morbidity and mortality among all ages of group. Identification of serious intra-ab pathology is often challenging. Many injuries may not be manifest during the initial assessment and the treatment period, according to the Medscape. So according to the Wikipedia, the abdominal trauma is an injury to the abdomen with the association of signs symptoms of abdominal pain, tenderness, rigidity, and bruising of the external. So this is the brief pathology. Okay, this is the pathophysiology of blunt abdominal trauma. So normally caused by the collision between the injured person and the external environment through the acceleration or deceleration forces acting on the person's internal organ. Blunt force injury to the abdomen can be explained generally in 3 mechanisms. First is the deceleration, 2 is the crushing, 3 is the external compression. For the deceleration, it creating a shear forces and causing a hollow solid visceral organs and vascular pedicles to tear. Example, the distal aorta is attached to the thoracic spine and decelerates much more quickly than the relatively mobile aortic arch. As a result, shear forces in the aorta may cause it to rupture. For the crushing syndrome, there is an intra-ab contents are crushed between the anterior abdominal wall and the vertebral column or posterior thoracic cage, causing a crushing effect and harm the solid viscera. For example, the spleen, the liver, and the kidneys. Lastly is the external compression. It refers to against an fixed object such as a lap belt, spinal column. It may result in sudden rise of intra-app pressure and causing the rupture of a hollow viscous organ. The illustration shows the organs potentially injured according to the region, such as the lower chest, anterior abdomen, flank, and posterior abdomen. This is a sign symptom of blunt abdominal trauma. Usually, patient will complain of having pain and tenderness. Also having symptoms of gastrointestinal hemorrhage, and patient showing hypovolemia symptoms, and also evidence of peritoneal irritation. So this is the physical examination. Lap belt marks correlate with a small intestine rupture, steering wheel shaped contusions, ecchymosis involving the flanks, which is the gray tunnel sign, retroperitoneal hemorrhage, the Cullen sign, abdominal distension. Auscultation of bowel sounds in the thorax may indicate a diaphragmatic injury. Abdominal bruit indicating the underlying vascular disease or traumatic arteriovenous fistula. Local or generalized tenderness, guarding rigidity, or rebound. Fullness and duffy consistency on palpation may indicate intra-app hemorrhage. Crepitation or instability of the lower thoracic cage indicates the potential of splenic and or hepatic injury. This is the illustration shows the Cullen signs and the gray tunnel signs. For the diagnostic examination, we normally do the EFA scan and the full CT scan, and also the diagnostic peritoneal lavage, which is known as DPL. This is the algorithm of management of the abdominal trauma. cc of loss. Usually, there is around third class or fourth class of shocks. This is the injury scoring scale for the liver. While this is for the spleen. So this is the management of the blunt abdominal trauma. For operative management, usually we do the surgical interventions such as laparotomy, and non-operative management, which is the conservative treatment. For the operative management, which is the laparotomy, patient was having the signs of peritonitis, uncontrolled shock or hemorrhage, clinical deterioration during the observation, hemoperitoneal finding after the EFAS and diagnostic peritoneal lavage, which is the DPL examination. For the non-operative management criteria is based on the CT scan finding and hemodynamic stability. In pediatric patients, oftenly transfuse up to 40 ml per kg of blood product in an effort to stabilize the patient. For adult, there is a hemodynamically stable. And of course, we have to do the close monitoring and frequent physical examination. For the laparotomy, before we do the laparotomy procedure, usually we administer with the broad spectrum antibiotics. Midline incision was preferred. Hemorrhage control by removing the blood and clots, packing all the 4 quadrants area, clamping the vascular structures. Obvious hollow viscous injury will be suture. After the repairs and hemorrhage control done, exploration of the abdomen will be performed to evaluate the entire contents of the abdominal region. After the intraperitoneal injuries are controlled, The retroperitoneum and pelvis must be inspected as well. Explore large or expanding the midline retroperitoneum with the anticipating of the damage to the large vascular structures, pancreas or the duodenum. After the source of bleeding are fully been stopped, further stabilizing the patient with fluids resuscitation. So this is the take-home messages for all. Primary survey and resuscitation goes hand in hand, so it is a ongoing process. Coagulability and hypothermia and also the worsening metabolic acidosis are lethal triad and need to be watched out. Fluid resuscitation is vital and evaluation of it is very important. CT scan is gold standard to diagnose an intra-abdominal injury in hemodynamically stable patient. So this is my thank you.